Welcome everyone to the 5,516th meeting of the Rotary Club of Chicago, the world's first service club. We have a very special program today, so we're going to skip several of our traditions, but I did want to just have a brief opening comment that this program today is in keeping with the tradition, the finest Rotary tradition of focusing on community health. From the first service project, building a public restroom in the city of Chicago, until today, Rotary has led the world in helping the world cope with every sort of health crisis, and this one is no exception. Today, we're blessed to have a wonderful panel led by one of our members. I'd like to introduce one of our very own, Andrew Dykins, who's going to lead the panel. Just a couple of quick rules. If you have any questions for our panelists, please type it in the chat box. We ask that people limit themselves to one question. You can ask more if there's time. But we would like to be respectful of everyone's time. It's early in the United States. We know it's late in Korea and in the afternoon in the UK. So we want to be very respectful of our attendees' time. And we have a very diverse audience from all around the world. I've counted at least 4 continents, and we may have more joining us. In any event, our leader today is Dr. Andrew Dykins, who is a board-certified physician in family medicine and an assistant professor in the Department of Family Medicine in the UIC, University of Illinois at Chicago College of Medicine. Dr. Dykins also is the executive director and founder of Peace Care, a nonprofit organization that cultivates sustainable global health solutions by creating enduring links between communities of need and entities of resource. He served as a Peace Corps volunteer in Mauritania, West Africa. The first time I met Andrew was when he was presenting his research study on the value of cooperation between not-for-profits like the Peace Corps and Rotary. Andrew has experience all over the world. We're especially proud of him because he leads a large global grant program that he put together in Senegal, and he's going to touch upon that because he has experience in Africa with the COVID response. Before I turn it over to Andrew, I just want to tip my hat to Eric Kempel, our president-elect, this was his idea. This was his brainchild, and he put together this panel. So thank you very much, Eric. And without further ado, Dr. Dykins.
Thank you very much, Marshall. And thank you all for joining us today. We really appreciate your attendance. I think this is going to be a very interesting panel discussion. And it is an honor to be with you moderating this discussion this morning. I'm hopeful for a very lively discussion. And we are thrilled to have with us today Professor Woo-Joo Kim from Seoul, Republic of Korea, as well as Dr. Keith Paver from Manchester, United Kingdom. Our third panelist, unfortunately, is unable to be with us today. Dr. Fabrizio Pregliasco from Milan, Italy, was unfortunately called away for an emergency this morning, or this afternoon for him, and unfortunately is unable to be with us. I would like to encourage you, before I move forward with my comments, to please engage with us this morning. We hope for this to be an interactive session. We would like to ask you to all identify the chat area of your screen. You can mouse over the bottom portion of your screen and identify the chat area. And please, we would like to ask you to enter your questions there for our panelists throughout their discussions. I'll be reading those questions for you, for the group, so that we can moderate those questions, but we really are counting on you to help us make this interactive and engaging. We have a lot of expertise with us, and there's a lot of opportunity for sharing rich information. So thank you so much. I'll give just a brief overview, just a couple words from my own perspective about our current situation and my personal experiences. But then I'm going to let the panelists take it from there. As Marshall mentioned, I'm a researcher that principally is working in Senegal, West Africa, where I'm researching cervical cancer, principally the uptake of interventions at the community level to encourage the uptake of cervical cancer screening services, and we're doing some HPV vaccine research. I spend about 5 months of my year in West Africa, and recently, just before the pandemic was more active in the United States, i.e. in February, I was in West Africa between January and March, and then came home just before we really started actions in the US to fight against the pandemic. And I wanted to bring to light a personal experience that I had that really illustrates how various and how different the engagement is of the populations, and how we are reacting at the national level to this pandemic. And that might give a brief perspective as to how we are experiencing this both individually and collectively around the world. And I think that's something that we're all really interested in, is to understand how we are experiencing this in each of our own individual places and how others are experiencing this, because there's a bit of a push and a pull here that we're seeing. What I mean by that specifically is that my work is really focused on a theory and an idea, of collective action, which Rotary brings to light. We like to think of globalization as an opportunity for us as communities and nations to work together to combat the pressing issues of the day beyond coronavirus. But what we're experiencing right now is a bit of a push-pull with that particular idea, and the idea that perhaps localization is the best way of dealing with certain things. And so I think that part of the conversation today might help us engage that question and find a way of reconciling the differences between this idea of localization and the idea of globalization, and how can we make that best fit. Because when it comes right down to it, we are a collective community, we are a global community, and we're all experiencing this together, albeit in our own unique ways. And that has a lot to do with political as well as other particular situations. So at any rate, let me give you just a brief summary of the numbers so that we can all be on the same page. Globally right now, we have 3.6 million cases of coronavirus and 252,950 deaths. In the past 24 hours, there's been about 709 new deaths. We have 1,206,000 recovered individuals to date. And just so you know, the United States numbers, we have 1,213,000 total cases, with 69,925 total deaths in the US. The country closest to us is Spain, with 248,000 cases and 25,428 deaths. Senegal, which I'm going to touch on very briefly right now, has total number of cases of 1,329 cases and 11 total deaths. So in early March, I was working in Senegal, and we were, the world was paying close attention to coronavirus, and many countries were already in the depths of this pandemic, and the United States was just starting to take action. And I knew that my travel was going to take me home just before more advanced action was taking place. I had the opportunity to travel down to Ghana for a week and a half, where we are working on setting up a partnership there. And in my travels, I experienced something very interesting. In leaving Senegal and arriving in Ghana, I began to realize that the preparedness of West Africa, because of the Ebola crisis that hit just a few years back, and is currently active in some places, the West Africa has been prepared in a way that many other parts of the world has not necessarily been prepared. I met at the airport, arriving in Ghana, a very systematic approach with a card asking for symptoms, and every single passenger on the plane was tested for temperature, and with a systematic approach to addressing anyone that hit certain criteria. That gave me a level of comfort of knowing that that they were dealing with this public health issue in a very systematic and planned way. When I returned back to Senegal, I experienced the exact same thing, with a very systematic approach at the airport, and a way of dealing with this. A couple days later, I got back on the plane and headed back to the United States, where I landed in New York, which at the time was very active in the coronavirus epidemic, and with many, many cases there. And I'll have to say I was very disappointed with the United States approach. We did not answer any questions, and no one on the plane in an international flight was tested for temperature. And so I think that that gave me an understanding of how unprepared the U.S. and many other places of the world perhaps were in dealing with this coronavirus epidemic. And I think that we're seeing a very interesting transition as we're learning a lot in the U.S. and we're learning a lot in other places, and we're sharing collective wisdom. And I think this is some of the value that we'll hope will bring out today in our discussion, is this sharing of information and the sharing of experience as we're learning from each other and finding ways that the collective knowledge and the collective wisdom can benefit us all. So with that, I'll leave my remarks and we'll move forward to hearing from our panelists. We're going to begin our discussion today by hearing from Professor Kim. And I'd like to just take a second to introduce Professor Kim. Professor Woo-Joon Kim is an infectious disease physician trained at Korea University Guro Hospital. He has held many prestigious posts. He previously worked as chief of the Laboratory of Respiratory Viruses and the National Influenza Center at the Korea National Institute of Health. Here he was instrumental in the establishment of the Korean Influenza Surveillance Scheme. He provides advice on issues such as the identification of priority groups for influenza vaccination programs, the appropriate vaccination campaign, surveillance, burden of disease studies, and vaccine safety. Since 2007, he has also been advising on the influenza pandemic preparedness plan at the Korea Centers for Disease Control and Prevention. During the 2015 MERS outbreak in Korea, he had served as a leader of the rapid response team and the special supervisor to the Prime Minister to help the government for ending the outbreak within 2 months. In addition, he conducts research and is well published in leading journals. We are honored to have him with us today. And personally, I was also thrilled to note that during his training, he served as a visiting scholar at Rush Medical Center in Chicago, United States. So who knows, he may even be a Chicago Bulls fan. Professor Kim, welcome.
Thank you very much, Dr. Dykins. I'm very happy to join this Chicago Rotary Club COVID-19 meeting. Yes, I was the fan for Michael Jordan of Chicago Bulls, and I was staying in Chicago from 96 to 97. So I'm very happy to join this meeting. So I'd like to share our experience, especially how to flatten the epidemic curve by COVID-19 in South Korea. May I have my PowerPoint slide? In South Korea, we have first COVID-19 case on 20th January. She is the 53 years old Chinese woman who traveled to South Korea for sightseeing. So Incheon International Airport in Seoul, during quarantine service, they identified the first COVID-19 confirmed case on 20th January. And we have many good lessons learned from 2015 MERS coronavirus outbreak in South Korea. During that time, Korean CDC and Health Authority, we have failed to contain MERS-CoV outbreak in May of 2015 because Korean CDC was not prepared well. So after initial failure of the containing MERS-CoV outbreak, Korean CDC quickly regrouped and enforced the diagnostic test and patient identification and treatment in the isolation room. And we followed the very thorough contact tracing by using a smartphone GPS system or CCTV monitoring system, as well as credit card transaction records. So from the many lessons learned from 2015 MERS coronavirus outbreak, this time after first confirmed COVID-19 case identified in 20th of January, our Korean CDC measure strongly to identify case and trace the contact person and have a home quarantine at least 14 days. So we have only less than 30 case until February, middle of February. Then all of a sudden there was a big outbreak in Daegu City. Daegu City is the third largest city in South Korea, have a 2.4 million population in Daegu area. So there was about 8,000 confirmed case occurred in first big outbreak. The highest number was the 909 newly confirmed case on 29th February. But Korea government, we did not measure like a lockdown of city. We did not perform lockdown strategy, but we follow the public health countermeasures and enforce the personal hygiene like hand washing and cough etiquette, mask wearing of people in the public space. So we could flattening the epidemic curve. So the number is markedly decreased middle of March. So we could decrease the number of newly confirmed case recently. So far we have nowadays today, as of May 5th of today, we have only 3 confirmed case, and we have 1,300 patients still in hospital, but more than 8,000 cases were recovered and discharged from the hospital. So next slide, please. Yes. As of today, the number of cumulative confirmed cases is 10,804 cases, and out of them, 254 deaths were recorded. So case fatality rate is 2.35%, which is much lower than that of the Western country, including United States. So the case fatality is very low compared to that of other country. And case fatality in men is more higher, 2.3% compared to the 1.9% in the woman. So it is a very similar finding reported in other country. And by age group, the most common age group is 20 to 29 years old, young adult group. They comprised about 3,000 cases, which is 27%. But there is no mortality among the young and children, young adults and children. But there were high mortality among the elderly, especially the age more than 80 years old. The case fatality rate was 25% and 10.7% among the 70 to 79 years old. So which is a very frequent finding reported in other country. Next slide, please. Yes, South Korea, we have a very strong public health countermeasure was implemented, especially in airport. We have a fever screening and strong health questionnaire, which include fever and respiratory symptom are occurred within 2 weeks. If there is a fever or symptom, the RT-PCR diagnostic test was performed in airport in the walk-through diagnostic station. And if there is a confirmed case, they were hospitalized special COVID-19 treatment center. Or if there is a symptom is very mild, those COVID-19 case with mild symptom, those people will be housed in the life and treatment center, which is more between hospital and home. And also there is no symptom in entry passengers. Korean CDC put the self-quarantine safety application or self-diagnosis application was installed in their smartphone. So those applications monitoring the position of the people in quarantine by using GPS system. So Korean CDC will monitor are there any violation of the escape from their home, or by using self-diagnostic application, the people in home quarantine report fever or respiratory symptom if there is occurred. So that's the information IT technology for monitoring the people in home quarantine. And also Korean CDC performed very wide and broad diagnostic test was done by using PCR in fever screening center in hospital or regional public health center. So number of diagnostic tests was done up to 20,000 tests every day in the peak of the COVID-19 outbreak. And we also hospitalized the mild, moderate to severe and severe case in the designated negative pressure isolation room for the more comprehensive management of those severe cases. So that helped decrease the mortality among the COVID-19 case. Also, Korean CDC and regional public health center monitor the contact tracing by using the GPS system or CCTV monitoring, even credit card transaction record. So Korean CDC thoroughly traced the contact person to the confirmed COVID case. So identify those people and mandatory home quarantine for 14 days. Also install the self-quarantine safety and protection app in those peoples. And regardless of the whether or not an individual display any symptom, person placed under self-quarantine will be prohibited from leaving their home for 14 days. And violation of self-quarantine regulation will result in up to 10 million Korean won fine or 1 year in prison. It is a very strong regulation was established since 2015 MERS outbreak. Next slide, please.
Professor Kim, we have flexibility, a bit of flexibility this morning, given the decrease in panel size, but I'd like to ask you to wrap up your comments in about 2 minutes, if possible.
Okay. Yeah. Okay. Yeah. Sure. Sorry. I would like to wrap up my talk about how to Korean government control COVID-19 outbreak in South Korea. Anyway, Korea, we are using very strong public health control measures, which was a lesson learned from 2015 MERS outbreak. We are also using information technology, and by using application or GPS or CCTV or credit card transaction record, it was those ideas are very helpful to control COVID-19 outbreak in South Korea. We also our idea drive through and walk through screening station was very efficient to test suspected case for confirmation of COVID-19 infection. So I would like to finish my talk. Thank you very much for listening.
Professor Kim, thank you so much for those remarks. That is it was wonderful hearing from you. We're going to go ahead and move into the next talk right now. I see some questions that are coming in, and so I really appreciate those. Please continue to place your questions, and we'll get to as many of them as possible. All right. So Dr. Keith Paver has worked in the field of public health for 40 years, spending his career working for the Public Health Laboratory Service as a research clinical scientist. During work on his PhD, Dr. Paver began to specialize in diagnostic virology and transitioned his career with consultant status with the Central Manchester NHS Foundation Trust. A major area of his work was in the diagnosis and epidemiology of hepatitis B and C and other bloodborne infections, and he played a significant public health role in the early years of the HIV pandemic in Manchester. For the last 10 years, Dr. Paver has also worked in epidemiology and quality control. He, as well, has taught part-time at both Manchester universities and was a member of the Health Protection Agency Northwest Regional Surveillance and Training Committees. Dr. Paver joined Rotary in 1987, serving as club president for the first time in 1993 and later as the Centennial District Governor in 2004-2005. He was appointed as one of the 41 In Polio Now coordinators for his current Rotary year and role in which he will continue after July 1st. He currently lives in Manchester, but that does not exclude the possibility that he is a fan of Sadio Mane, Senegal's national star who plays with Liverpool. Dr. Paver, many thanks for being with us today. We are looking forward to hearing from you.
Thank you, Dr. Dykens. It's a great pleasure to be with you, and I'm going to activate my slides now so that we can you'll see them instead of my face, which is not the prettiest thing in the world. Let's go play from the start. Hopefully you can see that now, and I will get rid of those. Well, greetings to you. Good afternoon from a sunny but rather cool Manchester. It's striking that ever since we've been in lockdown, we've had gorgeous weather, except for 1 or 2 days of rain, which is most unusual for Manchester, for those of you who know the city. I retired 12 years ago from the front line, for which I'm rather grateful at the moment, knowing what the workload must be like for my former colleagues and friends. And I've been able to watch the progress of this pandemic from the relative safety and comfort of my armchair, or at least my office chair. And I started taking an interest right at the beginning, about the end of January, because I was seeing, looking at the figures coming from China, something very similar to what had happened in 2002, 2003 with SARS coronavirus type 1. I was involved in the diagnosis of that in this country. Although we didn't have any cases, we still had to check people who entered the country, came to Manchester with any of the, shall we say, anything that fitted the case description we were working with at the time. Right. I'm just putting up, this is a slide from data from yesterday. I've not updated this morning. But this is a comparison of the top 5 or 6 countries in what we call Europe. I'm surprised Russia gets into Europe, since most of Russia is actually in Asia. But one of the things that charts like this, to me as a virologist, one of the dangers of them is that they allow for comparisons that don't take into account variation. And there is enormous variation between countries in the way that they record cases and in the way that they record deaths, and also in their demography and the behavior of their populations. And one thing you learn as a virologist is that the progress of an infectious disease, particularly an epidemic disease, is as much dependent on the behavior of the host species and the places that they live and the characteristics of those places as it is of the virus itself. It's disease is a relationship. Looking at the UK line, you can see that we have this very alarming figure of 28,000 plus deaths. And there is a lot of reporting that we are going to end up the highest death rate in Europe. That is very difficult to compare death rates across countries because we record deaths in different ways. It's also interesting, you see that the number of cases that we show, about 190,000, is quite clearly an underrepresentation of the number of people who are infected with this virus in the community. And the tests we have at the moment are tests for incidence, they're tests for current infection, and they're not tests for past infection, so we know nothing about the prevalence of the virus in the community, nothing about the number of people who've got subclinical or mild infections who are contributing to transmission of the virus. So I always sound a note of caution about data, and when I teach my students, I tell them that one of the things you have to do with data is to dig down and to understand what lies behind it. One thing is quite clear though, if we look at this graph, which is the graph of new cases, sorry, it does that, new cases in the United Kingdom, in England, not the United Kingdom, by date, it shows that we reached a peak around April the 8th or 9th, and that the number of new cases per day is declining. What is interesting, if you do compare that to the epidemic curves for other countries in Europe, our close neighbours, France, Spain and Italy, you will find that our epidemic curve seems to be rather longer drawn out than theirs. And we have to look at why that might be. But this graph confirms also things that we all knew, that the number of cases is greater in men as the death rate is greater in men, and that this is basically a disease that we only start to see when we're adults. That doesn't mean that the virus is not circulating in children, and that's something that is only time is going to be able to tell us. Once we can go back and do antibody testing, as we undoubtedly will. But I also want to look at local variation, because these graphs show something very interesting indeed. If you look at this graph in the bottom left, which is just the number of COVID-19 deaths reported to the Office for National Statistics, where everything ends up, all the statistics are brought together, and which is therefore always retrospective. But if you look at that map, you can see that in that period of about 6 to 8 weeks, 7 weeks, that there were large numbers of deaths in an area of what we call South Lakeland, up in the Lake District. And clearly, the reasons for those number of deaths are not the same as the increased numbers of deaths. The very heavy blue areas in Greater Manchester, in and around Birmingham, and in London. On the right, we can see that on the face of it, London and the southeast are showing a greater number of COVID deaths and a greater proportion. And the age standardized mortality rate in London is roughly twice that for the rest of the country. That masks differences between regions. So we know that in Salford, which is on the edge of Manchester, the age standardized death rate is well over 100. So moving on, and this PowerPoint is going up on your website to look at, because it's just for illustration. The top left is the more important one, is that instead of looking at deaths as they're being reported, if we look at excess deaths, which is the way that we always look at influenza and its impact on the community, what you can see is that if you compare to influenza and pneumonia, the 5-year average and the number of deaths in this year, that COVID-19 has leapt up from about week 13, which is the end of March, and is the major contribution to all deaths, the excess deaths above what we would expect. Other things to learn from this is that our major cities, again, Manchester, Birmingham and London, are young cities. Their population is much younger than the rural areas, and yet they're showing the greatest number of cases and deaths. But then we look at population density and see that there are also areas of greater population density. And looking at the map on the bottom right, which is areas of social deprivation, indexes of social deprivation, you also find that these are the places where you find the greatest social deprivation. And finally, ethnicity. And you'll see that the top chart shows the ethnic mix of the various regions of the UK, and show that London and the Northwest London has the biggest ethnic mix, and the Northwest follows after, and the West Midlands behind that. So some lessons. What have we done right? What have we done wrong? Well, this is just some headlines. The Prime Minister told us I think that's in the 17th of March, that actually we should stop traveling around, that we should, well, actually, we were told that we should avoid non-essential travel on March the 15th, but lockdown didn't start till March the 21st. On March the 15th, there had been only 2,683 cumulative cases and 43 cumulative deaths. 23rd, which is only 8 days later, the number of cases had jumped to 11,000, the number of deaths to 359. Remembering that the number of deaths represents what was happening 2 weeks before, when those people were and more when they were infected. So why didn't we lock down sooner? And that was because the government were afraid that we would not want to do it, that we wouldn't see this as being serious enough. Actually, I think, looking at what happened, probably we would have accepted that advice much sooner. Other things, our testing. Testing was originally only being carried out in one centre. Although we developed a test at the end of January, we only started to roll that out to more testing centres very recently, even though we had the capacity for PCR testing in many, many laboratories and universities and private places across the country. The big one is personal protective equipment. And basically, we for political reasons, we didn't join in a European initiative. And for reasons which based on the political choices made over the last 8 or 9 years, which had centralisation of all NHS supplies, we didn't have the logistics to get kit, PPE out to the hospitals quickly enough. We're still running a shortage, but it's not as bad as it was. It is more a question of getting it from a central supply to all the trusts than a question of actually there being the equipment there. And again, looking at the rights, this is about lives cut short. These are healthcare, many of them healthcare workers. We have seen a very marked relationship between ethnicity, black and minority ethnic groups have a greater death rate than the white population, if you like. But this is even more so. We find that the lower socioeconomic groups, the deprived groups, have a rate which is twice that of the general population. You could go on talking about this forever, but I just wanted to bring us finally to one or two questions I get from Rotarians and others. Is first of all, was this a surprise or should we have been better prepared? Well, this map, which I don't want to use, just a map of all the new and emerging infections, viral infections in humans since 1998. So no, it's not unusual, is what I tell people. And the next map shows you that the hotspots, the places where new virus infections are likely to arise, are the bright areas, and they will be for different reasons. And the reasons would be to do with declining immunity levels. If you come up into Europe, where people have stopped, because of vaccination scare, have stopped vaccinating their children. So we've seen an upsurge in measles cases in Europe and in Britain, and I know in the United States as well, a disease which was eradicated from Britain only a few years ago. So the other question Rotarians come to me with, which is related to that, is about polio. Is this like polio? No. Polio is a disease that was endemic and emerged as an epidemic disease, because the levels of immunity in the population started to fall for all sorts of reasons to do with improving living standards and so on. And the complicated calculations at the bottom, which show you that actually that it is, if given that poliovirus had a basic reproductive number of 6, meant that once the level of population immunity fell below about 84%, you would start to see epidemics of polio. This virus has come into a situation where nobody is immune and therefore behaves in a different way. But it does remind us that viruses transmit across boundaries and move across the world very rapidly in disease, indeed, because of our behavior, our air travel, and so on. So complacency about any disease is something that we should move away from, because if our vaccination levels against our endemic diseases or diseases we've eradicated from our European countries, if those vaccination levels fall, we could see a re-emergence of those diseases, which could be just as damaging as a new virus like this coronavirus. So what are Rotarians doing? I was asked to say what Rotarians are doing. Well, Rotarians in Great Britain and Ireland are getting very creative. The Rotarians who live near to me, in fact, in the club belonging to my district governor, have been collecting vegetables and fruit which are past their sell-by date or would have been thrown away, and are distributing to those people in need, to the elderly and vulnerable who can't get out to shop, but also to people who are living in much more dire circumstances than the comfort that most of us enjoy. That we are funding personal protective equipment. There is a proviso here that there are basic standards for the clothing, for the fabric of the clothing, which must be obeyed. And I'm afraid that some people have been making equipment and clothing from material that is not fulfill those standard requirements, and they're of no use. But we can buy the material and fund the material, and lots of people with skills with a sewing machine, Rotarians' wives, I think often, or I should say Rotarians these days, can knock up these scrubs using the proper material, which means that any shortage of supply, because these are often thrown away after a day, that shortage of supply can be dealt with. And of course, we are raising money. That we had a telethon on at the weekend, which unfortunately I couldn't take part in or listen to because I was dealing with another area of my life and commitment. But we are supporting this. And because of gift aid, every donation that Rotarians make to whatever this money will be used for, which is going to be in many, many ways, we'll get an extra 25% from the government, which is good. And that's the end of my slideshow, which I will stop now.
Dr. Paver, thank you so much. I'm going to take the opportunity right now to ask one question, and then we're going to get to the questions on the from the audience. And I'm going to limit the response to this to about a minute apiece, but I'd like to hear from both of our panelists. The question is, it is now the year 2035 or perhaps 2040. What should we have learned as a global community during the COVID-19 outbreak and preparing for the next global pandemic? Professor Kim?
Yes, you're asking what we are preparing for the next pandemic until 2040?
What should we have learned as a global community in preparing for the next global the next global pandemic?
Yes, I think the emerging infectious disease has already a lot of well-known. The risk factor of emerging infectious disease, scientific development destroy the jungle and frequent contact with animal and eating animal food and weather change, and there are many man-made influence a lot of emerging infectious disease. So we are lesson learned from those our past failure. We are save the animal and save environment and save the weather, prevent the carbon dioxide production. So we are lesson learned those risk factor for emerging infectious disease. We are save our animal and environment and our earth. That's the big lesson learned from COVID-19 outbreak also.
Thank you. Dr. Paver?
I'll take a different tack, and I would agree that everything that Professor Kim has said. I think that the first thing we learned is that we live in one world and we are all interconnected. We cannot say that what happens in China is of no interest to us. We are one global community, and the way we behave is that, so that there is movement between countries all the time. So not only should we have movements of people, but we should be transparent and totally open about what's going on in our countries. China is being criticized for not being transparent enough. I think that maybe at the very beginning they were a little secretive, but they have opened up in a way that when we had SARS in 2002-03, we didn't know about SARS until we had the cases in Hong Kong. But that sharing of information and of knowledge, based on knowing that at the beginning of a pandemic, we're going to be dealing in general ignorance rather than general knowledge. In other words, we are going to go on learning about this, and the true answers about this pandemic won't be known for another 2 or 3 years, all the factors influencing it. But that sharing of knowledge and information is vital. And also not being too proud to admit that we don't know what's going to happen, and that the basic fundamental research that is being done to look at diseases, not in humans, but diseases in animals that could become part of humans, it is vital that we continue to support that. In other words, science needs to be supported financially, science that we at this stage we might not see the value of, but we'll find out in the future.
Great, thank you so much. All right, let's move into the panel, or excuse me, let's move into the questions that are being posed by the collective group. There's quite a few coming in, so I very much appreciate that. I'm not sure that we'll be able to get to all of them, but we're going to get to as many as possible. And I'd like to ask the panelists to keep your your responses relatively brief, but let's try and move through some of these. The first one I'm going to select comes from Marshall Schmidt, and I would like to ask, he's asking Dr. Kim. Professor Kim, in your judgment, what is the most important factor in South Korea's success in containing the virus?
Yes, as a whole, in my opinion, government, private health authority, and medical community and general people all together lesson learned from failure during the 2015 MERS-CoV outbreak. So we are well prepared this COVID-19 outbreak compared to other countries because we are lesson learned from 2015 MERS outbreak. So this time we more earlier flattening the epidemic curve. Government and people, medical community, public health authority, all together, we are trying to get hard, contain, and flattening the epidemic curve.
Great. Thank you very much. Now, the next question that we'll pose, I think we can have a response perhaps by both panelists. And this comes from Mike Perry. We seem to have passed an initial peak in flattening of the curve of new cases of COVID-19 in many parts of the world. Many say this is an indication of the effectiveness of lockdown measures. The news is full of countries prematurely relaxing lockdown measures, often quoting economic reasons. Is there a danger that the lessons learned from the Spanish flu and other outbreaks of further much larger outbreaks being sidestepped for short-term economic gain?
Dr. Dykins, can I have a go at that one?
Please.
Yeah, in 1918, when the Spanish flu was in 3 waves, of course, it was the second wave that was the devastating one. And in Manchester, the Medical Officer of Health, with the agreement of the City Council, and bearing in mind that Manchester was at that stage probably the leading industrial city in the world, and therefore its economy was very important. But with the agreement, then they closed down the mills, the cotton mills, and the weaving, which could be quite devastating to the economy of the city. And the first wave of that pandemic didn't hit Manchester much at all, but the second wave, those restrictions were relaxed, and we had many more cases in Manchester in the second wave than the first. So the answer to Mike's question is that yes, that if we do relax too quickly, or if we relax without putting in place the sort of things that Dr. Kim has been talking about, that is contact tracing and if you like, the tracking of people's movements and relationships, if we do it without those things, yes, there is a risk of a second wave happening. So relaxation has to be slow, it has to be thought out, but has to be agreed. In other words, that this has to be put, certainly in nations such as Great Britain and the United States as well, where personal freedom is thought of as very important. It is important that whatever is done is with the full consent and understanding of the people, which is back to information.
Thank you, Dr. Paver. Professor Kim, would you have anything to add to this?
Yes, in South Korea, now we are recorded very low newly confirmed case. So from tomorrow, May 6th, Korean government easing social distancing measures and shift to everyday life quarantine, so-called everyday life quarantine. So primary and secondary school students will gradually return to school, and museum and sports facility will be reopened in a phased system. But anyhow, I'm also worrying about the big epidemic wave in autumn season. So we do not complacent to prepare the more big, very destructive epidemic wave in September or October, that will be very hard situation. Maybe South Korea will not handle easily compared to the first wave. So we already big 2009 H1N1 pandemic influenza in October 2009. There was a big epidemic in South Korea. So I think about during that time we have a Tamiflu for antiviral treatment for pandemic influenza, and we developed also pandemic vaccine that time. But this time we do not have any specific antiviral agent. There is no vaccine available in the autumn also. Without vaccine or without herd immunity, we will be very difficult situation. We will be very in danger in October, September epidemic season. So we should not complacent to prepare the next big wave.
Thank you. Let's move to a question from Jeff Sobel. This is a two-part question, but they're linked in the interrelationship of population density and travel. So let me read this, and I'd like to hear potentially from both panelists on this as well. Is the concentration of infection in the developed world attributable to population density and travel? And secondly, what are the implications for spread through the developing world?
Ooh.
Yes.
Can I take the first part of that question, Doctor? The first part is, yes, I do think that the heavy urbanization of our countries, and that includes South Korea, and concentration of people in cities does contribute to spread. It's interesting at the moment that if you walk on the streets, they are empty in Manchester, but normally if you were to gone out at a weekend, you would have had great difficulty not bumping into people as you walked along the pavements. And places like our places of entertainment and the nightclubs and so on, when you think that you get 3,500 people stuck in a space which is not much bigger than a gymnasium, which is part of the culture and young people's culture, you can understand how virus infections can spread, particularly those that rely on close contact, can spread very quickly. And the other bit is travel, of course, yes. And I think it is global travel that has meant that the speed of movement of a virus that is basically being transmitted between humans, not from an animal to human at that stage, but the spread of that is going to be only basically the time it takes for an aeroplane to fly from, shall we say, the furthest point from this country, which is Australia, to Heathrow, which is around 24 hours. You'll be from one major city to another. And anybody carrying a virus is going to bring it with them. So yes, it does. It is our love of traveling about is a problem, or has been. When you ask about the spread in the developing world, my belief is that the spread will be slower, but that it will happen without some means of finding out who's infected and therefore capable of transmission, and doing the same things that they've done in South Korea. That is finding out who's infected, doing the contact tracing. Maybe we should treat it more like smallpox, which was a virus with a longer incubation period, but which actually spread with people, nomadic peoples in developing countries as they moved about. And that maybe it is closer epidemiologically that what's going to happen to smallpox, to this virus, in those communities, that to smallpox than to the influenza. But that's just an idea, a theory.
Yes, South Korea is one of the highest population density country in the world. So especially Seoul and metropolitan area has about 20 million population, which is 40% of South Korean population. As you know, South Korean is very dynamic and very frequent movement, and they contact a lot of people. So that's why in the earliest of this COVID outbreak, we recommend mask wearing of general people in the public, even though WHO and CDC, they did not recommend mask wearing in the public at the time. So I guess, in my opinion, mask wearing in the public, especially in the highly dense area like subway and shopping mall, that was very helpful stopping the transmission of COVID-19 outbreak in South Korea, because it could not have a distance of 2 meters between peoples in those highly dense population area. So mask wearing in the public will be very good strategy in South Korea. That was worked. And in developed country, I'm very worried about the spreading and transmission of COVID-19 in developing country in like Africa and Southeast Asia and India or Bangladesh. Those countries are not well prepared to countermeasure and respond against COVID-19 outbreak. COVID-19 virus is a very highly transmissible, even could transmit in the asymptomatic or pre-symptomatic period. So I'm very worried about this COVID-19 outbreak will affect a lot of lives and mobility in those areas. Maybe some country will handle easily because they have a very strong government authority. Lockdown and homestay is very well disciplined in some country like Laos, and so those countries will control very well relatively, but other developing country will be affected a lot.
Thank you very much.
Can I add something to that?
Please.
There are two parts to that. One is about the wearing of masks. The UK government hasn't decided yet, and of course the WHO hasn't recommended it. But the London Mayor has suggested people should wear masks. Well, if I tell you that the Greater London urban area is an urban area of over 10 million people in a space which is no more than 25 miles in each direction, which gives and a lot of travel. 1 million people travel into the City of London every day on overcrowded public transport. I mean, I've been on the trains in Tokyo, and I've been on the trains in London, and I think that, and I've been on the trains in Rome as well. And I tell you that it's all three of them are alike. You are pushed together with people such that sometimes your feet leave the ground. But wearing a mask comes with a danger, and that is complacency. That if you're wearing a mask, when you take it off, you should immediately wash your hands, because of the very act of doing that, you contaminate your hands. But there's another side to this. I spent my working life wearing surgical gloves because I was working with HIV and hepatitis B in a laboratory, perfectly safe. My patients came in a bottle, but I wore gloves, and it modifies your behavior. The wearing of surgical gloves modifies your behavior. So if I watched every one of you, you would all be touching your faces about several times a minute. But if you're wearing surgical gloves, you don't. If you're wearing a mask, maybe you'll think about contaminating the surfaces around you from your hands. So I've always said to students as well, if you want to catch a cold, get on a Manchester bus just after the children have gone back to school in September, when they're all sharing their new cold viruses, and you will find that the surfaces, the poles that you hang on to are contaminated with human respiratory fluids, and you will get them on your hands and transfer them to your face and your mouth and your eyes, because that's what you do. And I think that the aerosol route is important, but I think that it is contaminated surfaces that we should be worrying about, and that is particularly true of public transport.
Thank you, Dr. Paver. So we are fast approaching, if not have already arrived at the minute where we need to wrap up this conversation. Marshall, can you guide us on how much time we have left to devote to this?
So I would like to get to some introductions, but maybe Andrew, if you could kind of sum up the discussion, and then we can move on. We have so many international Rotarians. I would like to take a little time to recognize some of them.
Wonderful. Yeah, I think that it's been an extraordinary conversation this morning. I very much appreciate the effort that has gone into preparing the presentations by Professor Kim and Dr. Paver. These have been extraordinarily informative, and there are many, many questions that we all have. There's many that you all have sent to us this morning. Unfortunately, we're not going to be able to get to, but let's continue to ask these questions. And I think that as a collective body, as a global community, we will continue to learn, and we'll continue to grow, and we'll continue to do the best we can in addressing the pandemic that is before us. And I think that the opportunity to come together as an international community this morning is very inspiring. And I think that as a parting word, I think it might be my preference to state, I think that this pandemic in many ways is very concerning and sometimes often scary. But it's also extraordinarily inspirational to see the ways that we can come together to address something that's very new, very different, and very foreign, and the way that we can come together in global communities, even local communities, but coming together to address this, I think, is very inspirational, and hopefully we can leave with that particular thought of the need and of being together collectively. So thank you all so much for being a part of the panel this morning, and thank you all who have joined us for participating as well. Marshall?
And I will echo those words of appreciation, both to the panelists, and Andrew, thank you very much. I think Andrew has struck the proper theme here. What impressed me about the discussion today is how similar we all are and how universal the experience is of people all the way from South Korea to the United Kingdom, and how we are all in this together, and we do need to work together to get through it. And in that vein, I'd like to just go through, we do have a tradition at the Rotary Club of Chicago of introducing our international guests. We're very lucky to have a very large crowd today to engage in this dialogue, which, as Andrew indicated, needs to carry on. But what I'd like to do is very, very quickly go through, and whoever would like to introduce themselves, I will call out people, and if you don't want to introduce yourself, that's fine. But if you could just give us your name and where you're from, very briefly, that would be very much appreciated. And I think we can start with Ksenia.
Good morning, everyone, and thank you very much for inviting me, because this was a very fascinating meeting and really, really deep insights. Thank you both speakers, and especially thank you for your opinion on surfaces. You're spot on, and I'm happy that I'm not the only one who is thinking about it. This is for all of us to remember that it is surfaces which is very, very dangerous. Thank you.
Gwyneth?
Yes, I'm from the Rotary Club of Wigan in District 1285, the same district as Dr. Paver, and I'm very proud to have been able to hear him today. Thank you.
Thank you. Gary Gruby?
Good morning.
Good morning, Gary. Where are you from?
Yeah, I'm a friend of David Hirsch's. Now he's embarrassed. Sorry for the delay, guys. Great session. Thank you very much. Love the international nature.
Yeah.
Very good.
Suresh, could you just introduce yourself briefly?
Thank you, President Marshall. Rotarian Suresh Rupchandani from Rotary Club of Ulhasnagar, Sapna Garden, 3142, India. And this is my second Zoom meeting with you. Last week also I had a delay. Thank you, Dr. Andrew, and along with the panelists, Dr. Keith and Dr. Ruju. A very good information. Thank you very much.
Yes, hi, Richard Knowlton from Cagliari in Sardinia in southern Italy, although you can tell by my accent that I'm a Brit. We're in District 2080 here. Great meeting, and I just love this international format. It's brilliant. Thank you.
Thank you. Sitaram?
Yes, I am from Rotary Club of Bombay Airport, District 3141. This is my, I came to Chicago also at that time, and I met with you and RI President.
Thank you for joining us. Jorg?
Hi, I'm Georg Schieber from Rotary Club Munich, Freedom. And I want to say hi from my dad. He was in our meeting for the last 20 minutes too, but he had to go to another meeting now, and he was joining out of his car. And I wanted to say that he was in hospital actually with this COVID-19 thing for 3 weeks. And we are happy and so lucky that he survived, because he had to wear an oxygen mask. He didn't have the ventilator, but he had the oxygen mask at least. But he made it at the moment, and it looks pretty good so far. He's back at work again, so that's good.
Well, thank you very much. You know, you've been frequent visitors at our club in the United States, so it's good to hear that he's on the mend. Nestor Ramirez?
I'm from here, from the United States. I'm in Champaign, Illinois, Rotary District 6490.
Thank you. Sue?
Hi, Sue Karstens from Rotary District 5390. And thank you. I really enjoyed this conversation as well, and I enjoyed visiting your club. Thank you.
Thank you. Anthony, it's a familiar face. It's good to see you. And I think you have some guests from your club as well. If you could maybe introduce them, that would be great.
Yes, Marshall, thank you very much. Great to see you, Marga. All friends from the Club 1. Yes, we have 5 members from the Rotary Club of The Hague Metropolitan, Netherlands. The Hague is the world's capital of peace and justice. And we just partnered with a club in Brazil. We just approached for $30,000 for a club that treats COVID-19 patients. The 5 members, let me see, we have here James Cass, Ajay Sharma, our incoming president, Ian Martin, and Amadou Kamara, the current vice president of the club. And we have our meeting in 3 hours from now, where we will comment about this one. Thank you very much.
Thank you. Giovanni, we're going a little slow here, so we may have to pick up the pace.
I was very impressed by the presentations. Thank you very much.
Thank you. Steve Munns?
Thank you, Marshall. I've really enjoyed this meeting. The last time I was with you was 15 years ago, I think, 2005. I'm from Region 19, the Foundation Coordinator. Really great. Thank you very much.
Thank you so much for joining us. Bruno?
Going to mute myself. I'm from Chicago, and I'm a new member. And I enjoyed the meeting. And I think what was interesting is to have some more data or some explanation of the data, because so far we're bombarded with death. But having more explanation about who are the population at risk gives some perspective to the data. And I think the more, to get back to a point that was illustrated before by Dr. Keith River, the more data you have, the better it is. Otherwise, it's propaganda.
Thank you. Jim Cass?
Thank you. I'm James Cass. I'm Canadian, but also part of the same Rotary Club of The Hague as Anthony. And I'm very pleased to be with you. And we had a coronavirus meeting a couple of weeks ago, and that was also very interesting. We'll certainly report on what you have very kindly shared with us. Thank you for inviting me.
Yeah. Edwin?
Hi there, Edwin Velarde from Rotary Club of Westlake Village, District 5240 in Great Republic of California.
Brenda? Looks like Brenda and guest. Well, looks like we disconnected Brenda. Andrea, our member, but an international Rotarian nevertheless.
Hello, everybody. Good morning to Chicago and good afternoon to Germany and the UK. Yes, I enjoyed this meeting very much, hearing perspective on Corona going on in South Korea and how it's handled in the UK. And unfortunately, we didn't have our presenter from Italy. I think that would have been very interesting too, since it was here in Europe hit in the very beginning, also with a lot of death. And I mean, in regards to COVID-19, we have a little difference between the southern part of Germany and the northern part of Germany. The northern part, where I am now, has not been as affected as the southern part. And so also now in northern Germany, we are starting to opening. This Friday afternoon, I have an appointment with my hairdresser. Haven't been able to go there for over now for me, it's about 10 weeks. So very excited about that. And the other thing that is exciting here too, restaurants are opening again, and they only allow half the capacity to come to the restaurants. But I think that was one of the things that I was missing the most. I mean, not working anymore and living here in a rural area where you can go outside whenever you want. I wasn't as affected as, for instance, my kids in New York. So I'm very grateful for being here right now and send the sunshine we have here right now to all of you. Thank you.
So I apologize to everyone. People in our club know how important time is, and we're kind of over here. So I apologize. I'm going to have to cut short the introductions. I want to end, however, with one introduction of a very special person who has survived this as well. Jenna, could you introduce your grandmother and very, very briefly tell us your story?
Thank you, Marshall. Hi, everyone. It's really great seeing you. This is my grandma, Gloria Greathouse. She was diagnosed with COVID-19 on April 14th. She lives with several comorbidities, sarcoidosis, congestive heart failure, pulmonary hypertension, diabetes, and she was treated in a negative pressure room in a Chicago suburb with high flow nasal cannulas. At one point, she was on 7 liters of oxygen. And she's just the heart of our family. And we've really had a really positive experience with the whole medical system. The hospital time was hard time for my grandma, but she's a very strong lady, and she took a notion to getting home, and she's been recovering here since she was released. She was in the hospital for 7 days? Yeah. 7 days. So if you want to say something, please feel free, but yeah. No, okay. Thank you so much, everyone.
Thank you, Jenna, and you and your grandmother are an inspiration to us all. Again, I apologize for not being able to introduce everyone, but that's a product of our success, and we are losing people because it's time to go. We at Rotary One traditionally end our meeting by reciting the 4-way test, and in this era of Zoom, what we do is we take one of our international Rotarians and ask them to do it. And today we are honored to have with us Patrick Tyrrell, who is the district governor in District 1285. He's from the Rotary Club of Manchester, which was founded in 1911. It is one of the oldest Rotary clubs. They do a series of projects and are very active in their local community at the Francis House Children's Hospice, the Narrowgate Homeless Shelter, and the Christie Hospital. Patrick, if you could lead us in the 4-way test. We're going to mute everyone except you so that we can hear you lead us in the 4-way test.
Thank you, President Marshall, and thank you everyone for joining in. I've just been looking at the 4-way test and thinking what people have been saying today and the way we need international cooperation on viruses like this. And the 4-way test is it the truth? Is it fair to all concerned? Will it build goodwill and better relationships? And will it be beneficial for all concerned? Thank you, Marshall.
Thank you all very much for coming and sticking out the meeting. Meeting adjourned.
Thank you.